welcome you all to the post-lunch session on this final day of the Hyderabad Lit Fest, and welcome to the Science and the City session particularly. In this session, we are going to discuss health in the city. Now, Hyderabad as a city is known for its health infrastructure, a city which actually taught me this term called as medical tourism also. And despite this kind of epithet that the city carries, health is still a concern for even for people like you and me, which I would like to think are actually the most privileged in the country. So what is really the city struggling with is what we will try to probe deeper into in this session. We will do that with two of our experts. We have Dr. Krishna Reddy, who is the founder of Access Health, and also one of the co-founders of Care Hospitals, which is this huge chain of hospitals in the city. Along with him, we'll have Professor Guy Marks, who's joining us from Australia. He's a respiratory disease public health expert, and if you belong to this city, you know that respiratory problems are our day-to-day problems now. So leading these two experts will be Dr. Surabhi Srivastava, who is the Chief Scientific Officer from TIGS, Bangalore, Tata Institute for Genetics and Society. She's a geneticist by training, and a lot of her work has been in that. And these days, she's really passionate to think of the problems that the country has and how can scientific tools be used to solve those. Surabhi, may I request you to take over? And Krishna and Guy, please join us on stage.
Thanks, Somdatta and the organizers. Good afternoon, everyone. Happy Republic Day, and welcome to this session on health in the city. So over the last 77 years, the urban population in India has seen a dramatic increase, as has our average life expectancy, which at the time of when we became a republic was around 35 and has now nearly doubled to over 70, 72. But with all these medical advances, we still have impacts of poor health affecting a large proportion of our population. Increased investment in prevention, early diagnostics, screening, and timely interventions is something that can bring down this cost both at an individual and a community level. So today, to discuss these issues, we have with us, as introduced by Somdatta, Professor Guy Marks. He's a respiratory physician and a leader in lung health, serving on the board of directors for the Non-Communicable Diseases Alliance. As a former member of the steering committee of the Global Asthma Network, I'm sure that name rings a lot of bells, and executive director of the International Union Against Tuberculosis and Lung Disease, Professor Marks is a leading authority in public health and chronic respiratory diseases. Welcome, Professor Marks. And we have with us Dr. Krishna Reddy, who I'm fortunate to know for some time now, a cardiologist and global leader for non-communicable disease prevention and management. As Somdatta mentioned, he co-founded several enterprises, not just care hospitals, also Relicis medical devices, driving the development of cardiac devices, including India's first indigenous coronary stent. Dr. Reddy, welcome. So I'll start immediately, maybe with you, Dr. Reddy. You're leading Access Health International, and you work closely with several governments, civil society, as well as academics to strengthen health systems across Asia and Africa. So could you comment on how these countries manage the implementation and access to medical innovations? How can we target healthcare solutions in our cities?
Thanks, Surabhi. This is my first exposure to Hyderabad Literary Festival, and just the previous session I enjoyed thoroughly. So one of the things I think the key purpose of healthcare system is to meet health needs of all people at all times. That means what they want, when they want, how they want. I mean, this is the ultimate objective of healthcare systems. With the rapid advances in science and technology, especially in the digital and the molecular technology, now one of the key issues is access to innovations. I mean, whatever innovations that are happening, Each innovation is to trying to address certain problems. It may be access problem, it may be affordability problem, or it may be an incurable disease, making it a chronic thing. And the pace of innovation is also much rapid. Earlier times, the bench to bedside used to take at least 2 to 4 decades. Okay. But the COVID actually demonstrated that it can be 12 months.
Yes.
So what is the lesson that we learned from the COVID? Why there should be a time delay in accessing innovation? So that means the timely access to innovation, a proven innovation. It may be diagnostic innovation or it may be therapeutic innovation. In terms of the governments, what they do, two things. One is the efficient way of the regulatory approval process. Okay. So one of the strategy people are adopting is what they call it as harmonization of standards. Like European Union, all the member nations have uniform standards. Now African Union have uniform standards. And there is an attempt for the global standard so that a technology developed in another country, if it has to enter another country, it takes again another 3-5 years. So this is one of the strategy to reduce the time to access. That is the first thing. But more importantly is the affordability to access. I mean, I think any innovation, if it is not accessible by all, that means everybody has equal opportunity to access it, what we call it as equitable access, then it does not serve the purpose. So that's where, again, I mean, the governments can only do X amount based on their fiscal space. They don't have unlimited budgets. Okay. So that's where they bring in the issue of who should be benefited the best. I mean, the whole concept of health technology assessment, whole concept of benefit packages, that is, so there is a limit there. On the essential drug list, essential device list, again, there is a limit there. Because what government thinks as essential, a patient may not think as essential. Because every patient or every patient family member may want the benefit of the new innovation. If it can extend by another 2 years of life, why not? They sell their house, they sell everything. So this is where the second element of what are the innovative financing mechanisms to enable people to access innovations. Okay. So there are blended financing, there are mutual aid, that is a crowdfunding, there are top-up insurance. So there are a lot of innovations. A government can facilitate that. I mean, there is a private sector innovation in terms of access to financing, the health financing. Because the government cannot do only this much. So we cannot expect government to do everything. So beyond that, government can enable by partnering with the private sector to achieve that. The third element, just before I conclude on this subject, so unlike the many diagnostics and the drugs, the challenge with the digital technology as a diagnostic tool or as a therapeutic tool, it is not going through the same rigor as a drug. As a drug, you are supposed to demonstrate that it is not harmful to the patient. It is safe. The next, you have to demonstrate it is effective. But most of the digital applications that are coming in, flooding the market, there is no such regulation in terms of, for example, if you have a wearable watch, you are recording your heart rate continuously. What is the unintended harm this is causing on the people? Is the anxiety levels have doubled, the self-treatment has doubled, wrong treatment has increased, rushing to emergency has increased. Nobody has anticipated this, unanticipated, the safety issue. So that is my caution, especially in terms of the digital technology, because the governments do not have capacity to regulate digital health tools.
No.
They don't have the capacity. Yeah.
That is a very valid point, and actually I will like to return to that later during our discussion. But I want to take up some words that you said in terms of community health versus individual health. It is not just enough to ensure that some people are enabled, because this is disease that we're talking about. And Professor Marks, what I understand is that this decision-making process, as Dr. Reddy just mentioned, for new technologies for public health, can be specific to a country or a union and its people. So, based on your expertise and your experience, could you give us some examples on how public health can be tackled for prevention, screening, and early diagnosis?
Sure, thank you very much. And first of all, I want to say thank you for inviting me to participate. I'm very honoured to be part of this event. I'm very happy to be back in Hyderabad. This is my second visit here. I was here for the union, the International Union Against Tuberculosis and Lung Disease, held its World Conference here in 2019. So I'm very happy to be back here again, and also I want to take the opportunity to wish you happy Republic Day and congratulations on this important anniversary. So thank you for raising the issue of public health. I just should say, by way of my background, I sort of straddle two worlds in medicine. I spent most of my career looking after sick patients in hospitals as a clinician. I'm a lung health clinician, but I'm also an epidemiologist and a public health doctor. And as you just said, the importance, we've learned much from COVID actually, and COVID sort of, suddenly people learned who epidemiologists were. Most people had never heard of an epidemiologist before COVID, and actually they realised that this is quite an important discipline. I think, to come to your question about public health, and how technology can be translated into benefits for public health. I want to talk, I'm hoping that I'll have a chance to talk about three different problems which are important here. One is tuberculosis, the other is asthma, and the other is the adverse effects of air pollution on health in general, all of which have important public health domains, but all of which are actually very different problems. But let's just talk about tuberculosis, important. We have now, and have had for a long time, the tools that allow us to diagnose every single person in the world who has tuberculosis. There is nobody who has TB who cannot be simply diagnosed with tools. We've had them for a long time. The tools we have now are actually much better than we had before. So not only can we diagnose them, we can diagnose them much more quickly and easily than we could before. Within a couple of hours, you can make a diagnosis of TB on any person in front of you. The other important thing to know about TB is that it's a transmissible, well, before I say this, the other thing that we have, which is very important to know about TB, we now have treatment that is effective for every single patient in the world with tuberculosis. I challenge you to find me a patient who has TB who I cannot treat. I've treated people who are 100 years old and cured them of tuberculosis. They've died of something else, but they didn't die of tuberculosis. But so it's a disease for which we can diagnose 100% of people and treat 100% of people, and yet in 2026, more people die in the world due to tuberculosis than any other infectious disease in the world. 1.3 million people per year die in the world, and a very large proportion of those people who die live in this country. Okay, very few of them, by the way, live in the country where I live. About 30 people die due to tuberculosis in Australia, which is a country of 25 million, but very many of them. And yet, this country has the technology and the tools. Many of the drugs that we use are developed and manufactured in this country at an affordable price. Many of the tools that we need to make the diagnosis are developed and sold and manufactured in this country and exported around the world, I would say, from this country. And yet you have this massive number of people dying and developing the disease. And one of the problems that we have, there are many problems, but one of the problems that we have is this sort of nihilistic attitude towards TB. This view that TB is a fact of life, that it's not a serious problem, there's nothing we can do about it anyway, let's just get on with life and deal with other problems that are more attractive to deal with. This is a tragedy, an absolute tragedy and an absolute injustice to the many people who are developing and dying of tuberculosis around the world, including in India. And so my sort of plea is that we use the tools that we have effectively to get rid of TB. And you can't do it by just one of the problems is that the traditional clinical framework, the traditional way in which we deal with problems is we wait for them to come and see a doctor, and if they're lucky, they get a diagnosis. If they're unlucky, they don't. But if they're lucky, they get a diagnosis, and if they're even luckier, they get effective treatment. But that pattern doesn't work. And one of the major reasons that it doesn't work is that for tuberculosis, like COVID, is entirely a transmissible disease. You only get TB, like you only get COVID, if you've been exposed to somebody else who has TB, or in the case of COVID, to somebody who has COVID. So we learned very quickly with COVID that what we needed to do was isolate people who had COVID and restrict interactions and stop people from being infected. With TB, we actually don't need to do that, because with TB, nobody actually needs to be isolated. They just need to be treated. The treatment for TB is rapidly and 100% effective in rendering people non-infectious to others. So finding and treating people with TB is the critical step in ending transmission of TB, and ending transmission of TB is the critical step in getting rid of the problem. Okay? So it's not about curing people, it's about rendering them non-infectious. I'll just make one other point, if I could, before I stop. And that the other reason why the clinical pathway doesn't work is that most infectious people with TB do not have symptoms. Most people who are, and that was the same, by the way, with COVID. Most infections from COVID happened from people who didn't actually have symptoms, were not sick. And it's the same with TB. So you can't rely on symptomatic patients seeking care in order to get rid of TB. You need to screen. You need to test everyone. And everyone, I mean everyone. And the point is that we now have the tools that allow us to do that cheaply and effectively and rapidly, to diagnose everyone and effectively treat them and render them non-infectious and get rid of this problem once and for all. And if we did this effectively, we could get rid of TB as a problem in India within 5 to 10 years. But we have to be serious about it. So I'll stop there. Thank you.
Thank you so much for that stark and very relevant reminder. So India has done better on TB in the last decade, with cases falling from something like 230 per lakh to now about 180 per lakh. But as Professor Marks mentioned, there's still far too many deaths, which are completely preventable because this is curable. So Professor Marks, just to continue on this, based on your examples from Sydney perhaps, how can we, the citizenry, do we have any role at all in nudging for impactful decisions, public health decisions that actually affect us?
So let me just say something about what the first comment you made. Yes, the prevalence is decreasing, or the incidence is actually decreasing. And over a long period of time, it will decrease with clinical care and with improvements in quality of life and social and economic conditions, but very slowly. And if we continue at this rate, we'll still be talking about it in 100 years' time, not in 5. And I want to get to the state where we're not talking about it in 5 to 10 years' time. I can tell you that in Australia, nobody talks about TB. In fact, the fact that I work on TB is thought of as a sort of curiosity. Why would you be working on TB? It doesn't exist. Most people in Australia and in the United States and Europe think that TB does not exist. It's no longer a problem. And why is that the case? It's not because they're rich. It's because they did what I'm saying needed to be done. They did it in the 40s, 50s, and 60s. In fact, people have known about this, that TB is an infectious disease, that you need to stop people from being infected, from well before we had drugs. We've had drugs since the 1940s. But even in the early part of the 20th century, people knew that TB was infectious. And what they knew was you needed to remove infectious people, usually to sanatoria. They sent them up to the mountains to remove them from the cities so that they would not continue to infect people. And that worked, actually. It didn't really help the people who had TB because they still died, but it stopped transmission of the disease. Now we don't need to do that, as I say. We don't need to remove or isolate or anything. We just need to find and treat people. So what do we need to do, to come to your specific question? I think we need to motivate, as civil society, as leaders and intellectuals, we need to get past this phenomenon of TB is just a fact of life, we should ignore it, we can't do anything. We can't accept that. It cannot be acceptable that people are still dying in massive numbers from TB, from a disease which we can diagnose and treat everybody. It cannot be acceptable. And I think you as leaders in this society, it's not for me really to tell you what to do, of course, but if you're asking, I would say that the thing is to try and motivate for the fact that this is a solvable problem, and we have the technology to do it. We just need to apply it in an effective way.
Just requires screening at a population
Yes.
scale and action. Yes, thank you. Let's shift gears a bit to talk about technology as a force multiplier. Especially in a country like India, technology has the potential to give us a huge advantage. For example, AI-supported clinical diagnostic decisions, digital wearables, which you just mentioned. There is scope for disruption even at the community level healthcare. So beginning with you again, Dr. Reddy, your thoughts on how such technologies can help us get closer to accurate and move towards preventive healthcare?
Yeah, maybe I'll start from the problem statement that was mentioned. I mean, that is relevant to tuberculosis, that is relevant to diabetes, that is relevant to cardiovascular disease. That means all the lifetime diseases or chronic diseases, and how the technology can overcome some of these gaps. I mean, the root cause of having the access to innovations, drugs, and other things. Now, improving the affordability already is there, but why we are struggling to control these diseases? I think that's the question that the discussion thrown up. The idea is not just individual doctor diagnosing or treating. Now, the health system is so fragmented. You have multiple specialties. You have allopathy and traditional systems. You have formal and informal systems. And increasingly self-care and other care. So given this fragmented system, what explains this failure is not only in India, like even in the US. For example, if I quote the heart failure study, despite the evidence, only 16% of heart failure patients were on proven 3-drug therapy. So what it actually triggered is, how do we actually address this issue of fragmentation and lack of coordination through integration and coordination? How do you integrate different specialists? How do you integrate different levels, primary, secondary, tertiary? So horizontal integration and vertical integration. So that's where the technology comes into the picture. See, one of the key integrator is the health record. Like a doctor, when he changes the shift, we record there so that the next duty doctor is able to understand what's happening to the patient and continue that care. But when the patient gets discharged, who is handing over that record? There is no handover of this nurse to the nurse or the doctor to doctor. In fact, this is one of the things that if you have a standards-based interoperable electronic health record system, I mean, that is what our Ayushman Bharat digital mission is aiming at, just like it integrated the finances through UPI, Unified Payment Interface. It unified all the taxation system through the GSTN. So there is a digital architecture that is being created so that there is a national level flow of interoperable health information system that is critical for integrating this fragmented healthcare system. And one of the things to improve the outcome is to have this integration. The second is who is taking responsibility to coordinate the care. As a citizen, suppose if you have 5 diseases or 3 diseases at different levels, you are going to the pharmacist, diagnostics, a doctor, a second specialist, but who is actually coordinating this entire care? Where is that family physician or primary care physician or a nurse coordinated? So these can be done. In fact, we are implementing a similar thing in state of Kerala, entire public health care system, since they already have electronic health record system. So there is already integrated, interoperable system. Now we introduce this simple process of a nurse in the primary health care handing over to the nurse in the secondary care when the patient is referred. Similarly, the hospital nurse should hand over to the primary care nurse. This simple handover process, simple referral, bidirectional referral system process. And once you have this minimal electronic health record system, you don't eliminate paper system, somebody is automating the monitoring. I mean, that is where your AI technology, which can crunch millions of data sets, can actually give a simple dashboard for the public health officer to monitor what's happening to the tuberculosis incidence, what is happening to the mortality, what percentage of diagnosed cases are actually under control of diabetes. So that is where I see the technology actually, I mean, just like any biological system, as a human being, our nervous system makes you a human being, right? I mean, all the integration of your different cells, different tissues, different systems, you require that unifying the nervous system. In a social system, it is the same example. The digital transformation is an inevitable evolutionary thing of a social organism. Like what biological organism has nervous system evolved. I mean, when your frontal cortex developed, that is what is AI. So it's a social evolution, a natural evolution of the digital technology that is essential to integrate this fragmented society, fragmented systems, especially in the healthcare system. So this is where I look at from how the technology should be actually leveraged. Not in a transactional, individual level, say I can diagnose tuberculosis by digital X-ray. Okay. But if you apply the existing tools, not even the new tools, in a proper process-driven way, defining care pathways, defining monitoring systems. So what we call it as a multidisciplinary disease management systems. So these are there. I mean, only thing is how to put into a gigantic system like in India with different states at different levels of capacity. But these are the principles of that. The second thing in terms of where we can apply the AI, for example, the doctors coming out of the medical schools, the variation is so much. When you go to an emergency, it is your luck who is there. Okay. But what AI can do is democratize that cognitive skill of an experienced cardiologist or experienced neurologist. If I can have an emergency doctor access based on these presenting problems and the background records, that these are the probabilities of this patient can have. So that means you are democratizing that cognitive skill. Okay. Similarly, the patients, there is an information asymmetry between the providers and the patients. I mean, a lot of misuse is because of this asymmetry. Patients don't know, doctors know. So that asymmetry is getting narrowed down because of access to information. But unfortunately, it is narrowing down. But if you have an AI which can extract authentic information, I mean, the infodemic of misinformation versus authentic information, you have ChatGPT, which is compiling the entire information, garbage, non-garbage. But now you have an extractable AI, that is XAI, which will tell you from where this information came from. It's not just information alone. because then you can authenticate, is it from, say, Mayo Clinic, or is it from Cleveland Clinic, or is it from WHO, or the NICE of UK, or ICMR? At least you know as an individual that this information is trustworthy. Like today, I mean, the WhatsApp, YouTubes, everybody is an expert in diet, everybody is expert on disease. That's where how you actually leverage AI is, I mean, just like a knife, you can kill a patient, you can kill a person, you can save a person. Same thing with AI. I mean, so what we're trying to use is democratizing the knowledge, cognitive skill knowledge among the doctors, irrespective of, I'm a cardiologist, but if my patient does not know, his body does not know that only heart is involved. And most of cardiologists will have chronic kidney disease, chronic lung disease, diabetes, and hypertension. So they need to, as a cardiologist, why should I refer my patient to these 5 specialists if I can be helped in the updated knowledge when to refer my patient? So patients also, if they have personal health records, I mean the ABDM now personal health record will be there. So if you can train the AI to actually triage, suppose in the middle of the night I have a chest pain, based on my background history of diabetes or something, and the nature of pain I'm describing, which is transcribed by the AI, it can tell you whether you sleep comfortably, it is not heart pain, or it is heart pain, rush to emergency, or there is a doubt, you get the next test done. I mean, it can be a first responder. So I think, see how you apply the technology to unbridgeable problems. Like telemedicine, it bridges the problem of access, the remote access. So don't apply to everything, because there are already solutions. It's a wasted solutions. But apply to those areas which is really can make a big impact rather than at individual level impact.
No, I feel the ABDM is definitely a systemic step in the right direction. But coming to this AI-assisted information that is available to each of us as individuals. So like Professor Marks, what do you think? How do we balance AI-assisted information with the importance of expert medical advice that can actually set you on the right track?
Well, I think Dr. Reddy has said much of what I wanted to say, actually. I absolutely agree with him. And you know, it's interesting that we both come from a background of sort of super specialist medicine, okay? But we recognise that there's a huge limitation on what we can achieve. Super specialists can't see most people who have the problem, particularly common problems like heart disease and lung disease and diabetes. Most people can't see the super specialists. And furthermore, much of the technology that's been advanced for trying to distribute that information does not work. Guidelines are either far too complex for anybody to follow or far too simple to be useful. So you simplify the guideline, and it's completely useless because it can't deal with the complexity that actually exists in patients. Or you make a 27-page document which nobody can use. So guidelines actually are not, in fact, useful on their own as a tool. And also training and education programs are largely useless because either they're too short and the participants don't get any useful information, or they're too long and nobody can actually attend. The information that's imparted is out of date almost as soon as it's imparted. And furthermore, people forget the information. And finally, the people who've imparted the information move on to another role. They leave the thing that you've trained them for and somebody else comes in. So our traditional methods of training and education and guidelines are just not fit for purpose. And this is where AI, and particularly authenticated AI or XAI, is really going to be very useful in, as you say, democratizing, making the information available at the point of care. The fact is, most care is going to be given by primary care doctors, or even not doctors, nurses or pharmacists or people working in the village, in the community, at a point of care. And most of those people the AI technology allows them to have access, not so much the patient. I think the key thing is not the patient, but the clinician who's making the judgment to have access to the information. The other part of it is actually where technology comes in here, is we're getting much better tools that can be deployed peripherally. So in my field, in respiratory medicine, by the way, about a third of all people who present to primary care or health posts with any problem, a third of those problems are lung health problems. They have pneumonia, they have a viral respiratory infection, they have asthma, COPD, or some of them have TB, or some other problem like that. So it's a very common problem in primary care. And at the moment, the diagnosis of most of those people is frankly a guess. No better than a guess. And yet we have the technology with portable, ultra-portable radiology, with AI reading of radiographs. We have the technology with point-of-care testing of sputum specimens, with point-of-care blood testing. We have the technology that is available to actually inform and make a much more informed decision about what the diagnosis is and therefore what the treatment is, or whether the patient needs referral or not urgent referral. So this just needs, again, it's about translating the technology we have, much of which is here in this country and has originated in this country and can be implemented in the AI tools for what are sometimes called clinical decision support software, or medical records, or whatever. There's a number of different ways in which they can be implemented. I think are vitally important. I think it's much more about providing that to the providers rather than necessarily the patients. Yeah.
I think that's a perfectly reasonable, balanced approach to take AI forward, but AI can only build on the evidence-based approaches that we are experiencing. And given the current state of the world, where science is being devalued, as I have to say, at a very rapid pace, especially medical expertise since the COVID pandemic has taken a deep hit. So how do you see, how can we still focus on evidence-based approaches, putting out reliable information sources? Professor Marks, do you have any comments to share on that?
Well, I'll just make one general comment and one comment specifically about the sort of evidence, and this comes back again to what Dr. Reddy was saying, that yes, there are validated sources like ICMR, like NICE, like Mayo Clinic and so on. But in general, the evidence that they're using is evidence from clinical trials. Okay, so the evidence that comes from clinical trials, of which there are a massive number, and there are data from those clinical trials, most of which unfortunately is proprietary, owned by drug companies. But if that data can be accessed, that data is in fact much more useful than the sort of observational data by just harvesting information about what actually happened to patients. The data that comes from clinical trials where you have a much more standardized method of assessing patients, of measuring outcomes, and also you have a randomized comparison between interventions, actually gives much stronger and more valid information to inform the AI algorithms. So I would be trying to get access to them for the AI algorithms. But the more general point you're making about the devaluation of science is, of course, a crisis. You know, the people who are heroes in our world, people like Fauci, who, you know, is a major hero, are being demonized, and people who are witch doctors, essentially, are wanting to take us back to the period of, you know, of the Middle Ages, of pre-science, pre-enlightenment. They're the people who are being held up as people whom we should take notice of. This is an absolute crisis, and we, broadly, the people here, you know, we need to stand up against it. We need to say that actually science matters. Science is the basis for where we've got to today. Massive improvement in quality of life and standard of living and length of life is on the basis of scientific innovation. And to denigrate that is an appalling situation, and it's a terrible crisis that we're in.
If we can focus on the positive side and how to move this onto the information highway, the reliable information highway. Dr. Reddy, with your work in a global health systems think tank, right? Are there newer methods and frameworks that we can harness to empower society for these approaches to healthcare, population health management, or some such framework that you can share?
Yeah, in fact, in the recent years, a lot of work we are focusing on the community empowerment. In fact, as a part of our health system resilience, empowering community and making community resilient is important for health systems resilience. Okay, so on that thesis, how to empower community. The existing, as I mentioned, alluded to earlier in terms of the information asymmetry. So one of the focus area has been on how do we actually focus on health literacy. What is the current level of health? So the general literacy, I mean, you may be a PhD, but in terms of the health literacy, you may be a school kid. So there is a more focus on how do we actually improve the health literacy. Okay. And now we have information access, but is it actually literacy? Are they learning correctly or not? The second is in terms of just knowing subject is one thing, but whether it translates into a behavior change.
Yeah.
Right,
Marx also mentioned
right,
that in terms of
yeah, right health-seeking behavior, right behavior in terms of adherence to the drugs and the tests that have been there. So these are the two things, at least we are trying to pilot in both urban population as well as in the rural population by what we call it as participatory learning action. That means where the community actually participates in the learning process. Because they know what language, what way of storytelling, what way of interaction, the peer-to-peer explanation or lived experience of a person who went through a heart attack or who went through a heart failure or who went through a HIV treatment is different from what the government does as a part of their IEC, Information, Education, Communication, is only the poster, putting a poster in every place. So I think there is a great role for now how the social media actually applies your behavioral science. I mean, they invest millions in behavioral science to know how to make you addict, how to change your behavior based on the social media content. So the same way, you can use it for a better purpose in terms of what method of, for example, we were doing a tribal village in the Kottagudem district, Kuttakoya, I mean, they live in the forest actually. So we have to take them through their dance lesson or their thali, what they are eating, to point each one, what is healthy diet, what is this healthy meal. So this is a powerful method of, so I think we need to change and invest, and this is the most biggest return on the dollar invested, is when you educate people on health and provide that education in a way that it can change their behavior. See, the behavior change is on two counts. I mean, one is by pain or pleasure. That is two methods. I mean, as per the Buddhistic teaching, the root causes of suffering is only this: craving for pleasure and aversion to pain. So you can use both techniques, so-called carrot and stick. The second is, nowadays, everybody knows, I mean, earlier we used to call key opinion leaders, the actors, politicians, science leaders, whom you look up to. See, if Rajnikant throws the cigarette and puts in the mouth, that influences so many youngsters to do the same thing. So, people who are in that position, the sports person, if somebody is popularizing pan parag, but who is acting on that opinion leader? I mean, people are looking that pan parag is good. The three leading actors are doing that. So nobody is assessing the harm that they are doing. People, they have that accountability to the society. If Modi sits in an asana on yoga day, say millions are influenced by that. Okay. But if Modi does not do that, so I think the responsibility of people in that position, the same way as a doctor, Suppose you are, because still, fortunately, the people trust their doctor to right or wrong the information they are getting from social media. So if the doctor is unable to do that in his actual practice, suppose, the doctor is weighing 100 kilos and is advising on weight loss. So, so that is one element of health literacy and behavior change communication. The second is the participatory local governance. That means how the citizens should participate in the local decision making of their own health at a local governance level. It can be done. And the third is acting as a watchdog. Okay. The fourth is with availability of so-called point-of-care devices, AI tools, the personal health record systems, you can be your own caretaker. Your family can be your own caretaker. That means if you are able to be digitally literate and health literate, you can be your own caretaker to a large extent, especially in health promotion, disease prevention, and early diagnosis. So these are the 3-4 interventions we are doing and trying to demonstrate. By doing this thing, are we going to make community more resilient to, we have seen during the COVID certain villages, how they implemented simple method of barricading their village. They did not allow people to enter. So I think there is so much can be done at community. That happens when the government partner with the civil society organizations, the community-based organizations, the patient organizations, elected local representatives. There are a lot of councils are there, but I think there is a huge scope to actually empower community. And then they become watchdog on the health system, whether the health system is working normally or not normally.
I think that is a great place to take a pause and empower this community. I would look forward to some questions for our experts here. So I can open for questions. Mics, please.
Hello. So I am Dr. Ashmeta. I currently work as an ICU intensivist. My first question is for Dr. Marks. We discussed a lot of things about TB, and previously I had been a part of National TB Elimination Program. So when I was in Odisha back then, and it's in Eastern India, and a major part of TB is contained to Odisha. And I want to ask, when I was there, the problem felt multidimensional from, as sir mentioned, health literacy, poor health literacy, to overcrowding and malnutrition, then lack of healthcare access for diagnostics. The biggest thing which I felt was lack of compliance to TB medicine even after diagnosis. So I would like to ask, considering the people who are mostly affected with TB, the socio-economic background to which they belong to, where do you think the bottleneck lies?
Part of the problem is actually trying to focus on too many things. Okay? So, and TB programs often get distracted by focusing on too many things. Actually, it's simple. All you need to do is screen everybody, find every case, and give them treatment. In fact, compliance is not usually the main reason that people don't take the medication. The main reason that people don't take the medication is they don't get access to it. They don't get the drugs in a timely way. And also, their adverse events are not effectively managed. But actually, in my experience, that actually adherence to treatment is not the major problem. It's often what healthcare professionals do is to blame the patient for not getting better. And I think we need to be very cautious about not blaming the patient for getting the disease in the first place and for not getting better. Usually, my experience, the vast majority of cases, the failure to treat TB effectively is a health system problem, not a patient problem. Okay, and I think we need to get away from the concept that this is a patient problem. It's not a patient problem. It's a health system problem that we have not effectively diagnosed them, we have not made the drugs available to them, we have not managed their adverse effects effectively, and if we do that, patients will take the drugs and will be cured. And will not only be cured, but will not infect other people. So I think there is a strong, and I've been a doctor for most of my life, and so I know there is a strong tendency to blame patients for the fact that they don't do well. We have to try and resist that temptation, okay? It's not usually their fault that they're not doing well. Can I just, while I've got the microphone, make one other comment about, because I agree with what Dr. Reddy was saying about the need for empowering communities. That is very important. I think there's also, though, a political dimension to this, and clearly the fact that patients or people in the community don't behave in the way that we would like them to behave is often because they are getting deliberate misinformation. And the misinformation, and why are they getting that disinformation? I mean, the most clear-cut is tobacco, okay? Why do people get the view that they should smoke tobacco? Why do leading sports players and actors smoke? It's because tobacco companies are literally paying those people to smoke, okay? And to show that they need to. And why are people exposed to high levels of air pollution, which is causing them to be sick? It's because industry has an interest in not being regulated in their emissions, and including from motor vehicles, from people who are selling fossil fuels. So there is a political dimension to everything, and even misinformation about COVID. You know, we dealt with a huge amount of misinformation. It was hard to understand sometimes what was the basis for that, but it was usually to increase the power, the political power of some particular players. So I think yes, we need to promote correct information, but we also need to combat the political forces that are promoting information that is harmful to health. And that is our responsibility as a community.
Essentially follow the money and figure out.
Follow the money, exactly.
Any other questions?
I have one for...
Can we give a chance to, if there's
sure.
someone else who has a question, and then we'll come back.
I'm a non-smoker, but when I went to my pulmonologist about 15 years back, he says I have a smoker's lung. Now, over the years, I have developed COPD in the meantime, and I was in the US, and I was perfectly all right there. I came back here, the air quality there was 10, here it's about 300. Now, given that we can't do anything about pollution, what is the way out?
Well, we can do things about pollution. That's the point. That's the point I was just saying. That, you know, it's interesting that today on the Australian Broadcasting Commission, the Australian National News Channel, the lead story was about air pollution in New Delhi. That was the lead story in Australia, which, you know, is quite interesting. And to say that we can't do anything about it is, I think, is not the point. We can do things about air pollution, and we need to. Look, from a clinical point of view, COPD has many causes. One of them is tobacco smoke. Another is occupational exposure and also exposure to pollutants. Others, post-tuberculous lung disease, post-infectious lung disease, a whole lot of things that can cause people to have COPD. And there is treatment for it. There is effective treatment that can, both drug treatment and non-drug treatment, which can improve the quality of life and survival of patients who have COPD. So there is no one answer to your problem. It's about trying to control all of the causes, including tobacco, including air pollution, including occupational triggers, including infectious diseases. And it's also about providing an accurate diagnosis with the right diagnostics and about availability of effective treatments. So all of those things I think are important.
Yeah, just I want to say a quick something, because we can't change the quality of air, but you can put a mask, N95 mask, to protect yourself. You should take your vaccines to prevent infections. If somebody, kid is going to the school, you wear a mask at home. When you're coming to my hospital, you wear a mask. So my simple question is, we can't change the environment. We can change ourselves. We can adopt these practices. Unfortunately, we lost the window of opportunity of COVID. We did not press upon to continue the same infection prevention control measures that we were doing, the social distancing, hand washing, face masking. COVID has gone, but influenza hasn't not gone, RSV has not gone, pneumonia hasn't gone, air pollution hasn't gone. So the government lost that window of opportunity. But as a citizen, you can do these three things. I mean, simple things: vaccine, masking, and protecting in the public places and at home.
Not only did we lose that advantage, it's like we've disadvantaged. It's masks are frowned upon now, and there's anti-vax going on. So yeah, those are both very valid points. Any other questions? And then we'll, yeah, please go ahead. We have to.
Good evening, professionals. My question is, Mr. Reddy, you mentioned about a faulty system as far as healthcare is concerned, which we all understand. My biggest concern is I represent, by choice, Senior Citizens Wellbeing Center. And it breaks my heart to see that when we approach insurance companies, because that's a mandate by the government, it's phenomenal. Some even refuse to take on. And I'm talking about members, we have 450 members who are 70 and above. In spirit, they're alive. They have a desire to live longer. But yes, there are maintenance requirements which healthcare industry or hospitals charge a phenomenal fee, even if it is for a regular checkup. So for senior citizens of our country, my city in particular, Hyderabad, where do I look for any form of support, a friendly support for senior citizens? We are in an aging community. We are in an aging generation, and we are being neglected. Now, with due respect, if you're a hospital owner, you understand what message I'm conveying here. So please give us some avenue where we want to live a life of end of life in a dignified manner. I've lived in the UK, I've lived in other countries, where if we age, we don't have fear of rotting in a lonely bed somewhere abandoned by the whole society. So please help us with this. Thank you.
Yeah, I think this is a real problem, not only in Indian context, the aging problem. So one is, from a policy perspective, at least there is a protection, financial protection for senior citizens as part of the Pradhan Mantri Jan Arogya Yojana. Unfortunately, the state of Telangana hasn't signed as a part of the PMJ. So this voice has to be brought to the notice of the decision makers of Telangana, I think, which we should be enabling that you are doing disservice by not extending this benefit to the senior citizens. The second is there are alternative methods of innovative financial protection, what is called as Mutuelle. I mean, this is very popular in Rwanda, in Africa. Mutuelle is on a website. All the senior citizens come together because it's a pooling. When you have a group insurance, people don't decline your insurance, don't charge you abnormally high because it's a pooling. Your risk is pooled among 1,000 senior citizens or 100,000 senior citizens. So that is the second solution that can be definitely there. The third thing, in a societal angle is at least some of the experiments that are happening in Thailand and China is, why don't you revive the traditional culture of the combined family while preserving your spaces. You preserve your individual space, nuclear space, by designing your housing complexes. You are staying neighborhood, may not be in the same house. So these are the societal interventions that are, I mean, instead of old age homes, elders have to be taken care in the community they live in. So yeah, there are, I think, a lot of things are possible. It is, only thing is there has to be a connection between the decision makers and the citizens' voice. Maybe, in fact, we are planning to convene a meeting, roundtable in Hyderabad with Health Minister and other civil society organizations, stakeholders, to bring some of these issues and also show them what are the solutions that are attempted by other countries or other systems. Yeah, within India, if you go to Kerala, I mean, they have, as a part of comprehensive primary health care, there is a special division for geriatric medicine. So it is a part of that. Yeah, we can just copy what is already being done within India as well.
Yeah, thank you. So in the interest of time, I think further questions and discussions we can have outside post this session. Circling back to where we started this, life expectancy, yes, it has increased from compared to earlier generations, but they probably lived a bit healthier than we do today, right? So public health requires a nuanced approach, as we had discussed some points today. But I think one takeaway that I would like to take from this that emerges is that public health is not just a political agenda or a policy agenda or a clinical agenda. It's something that impacts each one of us. And it's time for all of us to start thinking about this in terms of our individual health and our community's health. Thank you so much for joining in this session, and many thanks to our expert panelists for their time and your attention. Thank you.